Hi everyone, and happy Friday. Welcome back to the Bold Response podcast. I'm your host, Melissa Barr, and I can assure you that we'll be making your head explode with all of the information we'll be offering today. Pun intended. If it wasn't obvious already, we will be talking about exploding head syndrome, also known as EHS. We intend on introducing two patients to offer firsthand experience of having the disorder and two researchers who are considered experts on the disorder throughout the scientific community. First up, we'll be hearing from our first patient with EHS, Anna, who has kindly volunteered to share her experiences with us today. Hi, Anna. Can you introduce yourself and tell us a little bit about what EHS is for someone who has never heard of it?
Hello, thank you for having me. I'm happy to be here. Anyone who hears the disorder exploding head syndrome is bound to believe this must be a painful condition, considering its name. Although it does sound painful, it's actually not. Dealing with exploding head syndrome, the signs and symptoms I've experienced have been hearing loud noises or explosion in my head, feeling anxious or frightened after an episode, experiencing sudden involuntary muscle jerks during the time of episode, having a hard time falling back asleep, waking up sweating, having a rapid heartbeat, and or trouble breathing. The sound is terrifying, super loud, like someone has broken into my house. These symptoms can vary from person to person, so it all depends on an individual's specific and unique case.
Wow, that's so interesting, Anna. I can't imagine waking up to something like that as I'm sleeping. Can you run us through really quick what your daily and nightly life is like with someone with EHS?
In terms of my daily life, I do not have any problems. The real issue begins at night, usually as I'm falling asleep, or sometimes EHS wakes me up during the night. I sometimes hear sounds in my head such as explosions, gunshots, thunder, and other loud noises that I can't really describe. I experienced episodes of EHS several times in one night, but my doctor has told me that other individuals sometimes only experience EHS episodes several nights in a row, and then they never experience them again for weeks or months on end.
I'm so surprised, honestly, because I had no idea that some people can experience an episode once and then never again for months. That's crazy. But I guess with that being said, Anna, what are the challenges that individuals with EHS or their bed partners routinely face that you would like people to know?
I often find myself dealing with increased anxiety, among other challenges, in dealing with EHS. I fear going into my bedroom sometimes because I'm scared that as I fall asleep, or I am asleep, I'll soon be woken up in fear and anxiousness. Since people like me with EHS often have trouble sleeping at night, depending on the frequency of our episodes, we also are increasingly sleepy during the day. Considering I wake up in fear and panic, it usually disturbs my partner and wakes them up as well. So it is something that's affecting both of us, whether it's directly or indirectly.
So transitioning from the general discussion of what experiencing EHS is like from a patient's perspective, I know many are probably wondering what methods or procedures are characteristics for obtaining an EHS diagnosis. We will be introducing an expert who has researched EHS for decades from the Ohio State University, Dr. Souls. Can you please elaborate on this?
Thanks for having me. I would be happy to elaborate. The diagnostic options for EHS are generally limited. Honestly, it comes down to recognizing the most important symptoms of the disorder and self-report measures. Diagnosis is typically made by clinical history, meaning that testing on the patient is typically not required. Self-report measures are commonly implemented to understand the symptoms a patient may be experiencing.
Can you give us some examples of the self-report measures that may be used?
To my knowledge, also discussed by Sharpless in a review of EHS, there are 3 self-report measures that have been identified for diagnosing EHS. First, there's the Duke Structured Clinical Interview for Sleep Disorders, which consists of 3 prompts structured with clear wording for the purpose of being easy to administer in a clinical setting. Then, there's the Munich Parasomnia Screening, which includes 1 item rating past and present EHS episodes. If the rated episodes are present, a 5-point frequency scale ranging from very seldom to almost every night is rated as well. A third self-report measure may be used that only contains 1 EHS item, but there are complaints of ambiguity in the prompt that may lead to more false positive responses.
So, in regards to self-report measures specifically, I have learned from previous interviews with researchers specializing in different neurological disorders that there are drawbacks in relying on self-report measures as your only means of assessment. Is this the case for EHS?
It is definitely true that self-report measures cannot always provide the most accurate assessment of a patient's symptoms to lead to the proper diagnosis. However, with the present limited ability to exercise other forms of diagnosis, we do have to rely significantly on self-report measures for differential diagnosis. However, a common limitation of these self-report measures for the diagnosis of EHS is the inability of the prompts and the lack of explicit questions to provide differential diagnosis and discussion of comorbid conditions. If we could improve on this, EHS would be much more accurately represented in clinical settings.
Okay, that is definitely important to know. So I appreciate your commentary on that. Beyond self-report measures, are there any other neurological observation techniques that can indicate the presence of EHS symptoms for diagnosis?
Well, EEGs can sometimes be used to verify that these episodes are happening when the patient is awake, as they normally do. EEGs of EHS have always shown that alpha activity seen when someone is awake predominates along with some shorter episodes of theta waves. Although many patients report these episodes occurring when they are asleep, no studies that I am aware of have observed EHS during sleep, but instead in periods of relaxation or drowsiness.
Wow, that is very interesting. I read a research article prior to our interview regarding patient reports of their experiences, and I do remember them typically recalling episodes occurring while they are asleep. Is there an explanation for why they may remember being asleep rather than awake when their episodes occur?
The possibilities I would consider for this are that there may be potentially a variant of sleep state misperception or just the characteristic of experiencing EHS being distressing and unexpected that could contribute to any confusion in recalling the episode.
That makes sense. It does sound as though it would take a toll on the mental state of those experiencing the disorder, especially for a prolonged period of time. So, we discussed EEGs. Is there anything observed in an EMG as an EHS patient?
Yes, I'm really glad you mentioned that because I honestly may have forgotten, though it is important to understand. Typically, a short alerting effect will happen right before an EHS episode. This means that there will be a sudden increase that can be visualized on the EMG. There's also beta activity seen while alpha activity is simultaneously blocked during this effect.
Awesome! I can see how only visualizing the EEG and EMG may not point directly to EHS, as these observations can be characteristic of many other disorders/disruptions. Speaking of, I know you mentioned earlier that a limitation of the self-report measures is its role in differential diagnosis. What are some similar conditions that have been considered differentiation for the purpose of ruling them out during the diagnostic process?
From my experience and knowledge of the literature, this is a big hurdle that needs to be crossed in the assessment process of EHS and may lead to misrepresentation of the disorder in both the clinical setting and the general population. Less severe and more common issues, such as migraines and sleep paralysis, must be ruled out to address the other symptoms that arise with EHS. EHS can often be confused with nocturnal epilepsy, which is when the utilization of the EEG is helpful, because EEGs for nocturnal epilepsy are inconsistent with those of EHS. For the purpose of differentiating between headaches or headache syndromes like hypnic, thunderclap, and migraine cluster headaches in EHS, clinicians typically address the duration of the attacks when they occur and whether or not they feel the attacks are characteristic of only one side of the head or the whole head. As discussed before, EHS episodes are generally brief, frequently occurring during twilight, and are not characterized by lateralization of the head, distinguishing them from headaches. To decipher between EHS and more severe conditions such as subarachnoid hemorrhage and chronic paroxysmal hemicrania, as mentioned by Serrani in an additional review of EHS, the presence and level of pain is significant. EHS is typically described as more distressing than painful. The presence of intense pain would mean that a subarachnoid hemorrhage should be considered. Lastly, nightmare disorder and PTSD flashbacks need to be differentiated from EHS. To do so, self-report measures are helpful in identifying a lack of content and elaboration that are characteristic of EHS episodes when compared to nightmares and flashbacks.
That is a large bulk of information to consider for differentiating conditions, especially because, from my knowledge, there are mostly difficult issues to address objectively rather than subjectively. It must be significantly difficult to rely on descriptions by patients for this purpose, especially if the prompts involved in the self-report measures are not clear. Are there any other reasons that EHS often encounters issues of misdiagnosis?
Great question. Honestly, EHS is just so infrequently assessed, is rarely ever the main issue a patient is experiencing or presenting, and causes so much distress for patients that it is difficult to assess, and difficulty in assessment often leads to misdiagnosis. We are hoping that advancements in the research will take place to allow us to better characterize symptoms in an objective manner and conduct accurate differential diagnosis, but it is going to take time.
I'm hopeful for those who specialize in the field that some breakthroughs will be made, especially for the sake of the patients who have to experience these distressing episodes. Since we have gotten a general idea of EHS as a sleeping disorder, it would be helpful for our understanding if we knew whether it is considered dysomnia or parasomnia. What is EHS characterized as?
EHS is best known as a sensory parasomnia, since it is a very disruptive sleep-related disorder consisting of unusual behaviors and perceptions.
This has been significantly helpful for my understanding of EHS diagnosis, and I'm for sure that our listeners feel the same. I think now it would be best to discuss the etiology of the disorder for a more thorough analysis. So, how do people come to have this disorder? Is it passed down through families?
Currently in our research, no genetic risk factors have been discovered and a specific etiology has yet to be determined. However, there have been a number of proposed causes of EHS. Some hypotheses include partial seizures within the temporal lobe and ear pathologies such as eustachian tube dysfunction or disinhibition of the cochlea and its temporal lobe connections, altered attentional processing during sleep-wake transitions, migraines, sudden withdrawal of benzodiazepines, and a delayed decrease of reticular formation activity during sleep-wake transition. Additionally, others believe there may be a gene mutation causing transient calcium channel dysfunction that may explain why some studies have reported some patients to have a family history of EHS.
Are there any identified risk factors then to developing EHS?
While it used to be thought that this disorder was more prevalent in middle-aged women, it has more recently been found to be seen across age groups. Additionally, much of the research done on this disorder have been case reports, so the true gender prevalence can't be determined yet.
Does this research fit with what you have personally experienced, Anna?
I have noticed a trend in myself of having more events during periods of intense stress and after periods of insomnia. I've heard that this has been seen in other patients as well, but not in all.
Are there other common conditions with EHS? Other symptoms that often go hand in hand with this disorder?
In terms of comorbidities that occur frequently in patients with EHS, there are a few. For one, there's a high prevalence of individuals who have a history of sleep paralysis also having EHS. One study found around 37% of individuals with sleep paralysis also experience EHS. Additionally, there's a prevalence of hallucinations, nightmares, and lucid dreams in individuals with EHS, though the connection between these conditions has yet to be discovered.
Anna, have you experienced any of these conditions?
Personally, I have a history of lucid dreaming along with my EHS.
We have another patient here who has experienced EHS firsthand named Dish. What about you? Do you have any history of any of these symptoms?
I have a history of sleep paralysis with my EHS.
Okay, now we're going to get into the detailed neuroscience of what we know about exploding head syndrome, or EHS. Along with Anna, Dish, and Dr. Souls, we have Associate Professor Joel David. Welcome, Dr. David. Moving forward with what we understand about the distinctions of EHS, what can you tell us about what we know about physical or maybe even neuroanatomical abnormalities that can be found in the brain of a patient having EHS?
Unfortunately, due to rarity of EHS and its peculiar nature, there isn't much activity detected that can be considered isolating. We know that from previous studies conducted to observe patients with EHS, there have been no significant observations of anatomical difference of the brain. All that we do know is that patients associated with the syndrome are found to have symptoms pertaining to other sleep disorders such as insomnia or sleep paralysis. The best we can indicate a sign of anything happening in patients with EHS is by observing their sleep waves, and here it is noticeable that the occurrence of episodes have some sort of pattern. We can see that episodes of EHS can be seen during stages of NREM 1 to wake, or even after being woken up out of NREM to sleep. Other than that, very little research backs any commonalities between EHS patients that most likely are due to how abstract and rare it is.
I see. It's very unfortunate to see that the answer isn't as straightforward as we thought. If there are no observable differences via EEG, fMRI, etc., would that imply that there wouldn't be so much of a neurochemical or electrophysiological difference in someone with EHS?
This is where things get interesting because although the brain's integrity remains, what goes on in the network is where things get intriguing. What we know from ongoing research, the reticular formation is automated to be inactive during transitions of sleep. But what some researchers have found is that patients with EHS have reticular formation that has trouble doing so, and thus it causes some abnormal sounds to them. One paper I recall reviewing had information on how an EHS patient had a sarcoidosis, which is an inflammation in the brain. This patient was given an MRI and found to have a lesion around the pons and mesencephalon region. The patient was treated with a drug that was responsible for treating epilepsy and has the pharmacological function of reducing nervous activity. With the use of the drug, there were reduced symptoms of EHS in the patient, implying that there may be impaired GABAergic transmission from the periaqueductal gray to the serotonergic neurons in the dorsal raphe nucleus.
Given all that we know about EHS, I want to delve further into discussing the recommended medications for EHS. According to my research, there seems to be really no medication available to solely treat EHS, but rather to address and alleviate the symptoms associated. What are some of these medications, and could you elaborate on their neural mechanisms?
You are correct in that there are no FDA-approved medications that are used to treat EHS directly. What we do have are a plethora of medications that work as symptom reducers. Two commonly prescribed drugs are topiramate and amitriptyline. Topiramate is a useful anti-seizure drug that is prescribed for EHS. Topiramate's primary mechanism of action involves preventing the excessive neuronal excitement that causes seizures. This is done by exciting GABA release and inhibiting glutamate activity. Topiramate also blocks voltage-dependent sodium channels, which are responsible for the propagation of action potentials in neurons. As previously mentioned, EHS is associated with minor seizures in the temporal lobe. So the reasoning here is that if we reduce the risk of seizures, we may also be able to reduce the risk of EHS episodes. Amitriptyline is prescribed as an antidepressant. It functions by increasing serotonin production and inhibiting reuptake, allowing for the reduction of symptoms of anxiety that are commonly observed in after an episode, and boosting the overall mood of the patient.
Wow, these drugs can really help reduce some of the more severe symptoms of EHS. That being said, are there any notable side effects associated with these drugs that our patients or listeners should be aware of?
Yes, of course. Like most drugs, these also have side effects that should be discussed in more detail with your respective provider to see if they are applicable to you. In topiramate, we typically observe allergic reactions, depression, thoughts of suicide, and difficulty breathing, walking, speaking, or hearing. When it comes to amitriptyline, we can see allergic reactions, seizures, hallucinations, and confusion. There is still quite a bit of side effects associated with each drug that I have not mentioned, but these are some of the more concerning ones.
I would be lying if I didn't say that some of these side effects will raise a few eyebrows. I would like to reiterate the fact that these should be reviewed and addressed under the care of a licensed professional. So, for our listeners, please contact your provider before making any assumptions. At this point, I think it's also good to address the possibility of alternative treatment options that are non-pharmacological. I have previously read that CBT-1 can be used to address a variety of sleep disorders, but is it a viable treatment method with respect to EHS?
That's an excellent question. Similar to medications, cognitive behavior therapy can be used to alleviate symptoms of EHS. In this case, insomnia, which is quite common after an episode. I could only imagine how difficult and scary it must be to fall asleep after hearing such rattling sounds while sleeping. That being said, what we need to understand is that cognitive behavior therapy is specifically used to help establish healthy sleeping patterns through intervention and therapy. Currently, there is no research indicating that cognitive behavior therapy is directly helpful in reducing the risk of EHS. However, it can be used by itself or in combination with medications to alleviate insomnia associated with EHS.
That is very interesting, although it seems to me that there are unfortunately no unique or specialized treatments for EHS. Is that an accurate assumption? And if so, are there any preventative measures that patients or the general audience can take to reduce the risks of having an episode?
That is indeed a conclusive assumption. There has not yet been any significant research conducted on EHS that could lead us to developing new medications or treatment strategies that directly address and reduce the risk of EHS. However, we shouldn't be discouraged because there are many medications and non-pharmacological approaches to help manage episodes. Specifically on preventative measures, I think a better way of describing that would be referring to it as a risk-reducing strategy, as there are no point-blank preventative methods for EHS. These strategies include simply getting your recommended 8 hours of sleep a night and making sure you try to fall asleep and wake up roughly at the same time. Yoga, meditation, or other stress-reducing activities can aid in lowering your chances of experiencing an episode. If you feel like you have anxiety that is causing EHS, I would recommend consulting your physician, who can either provide you with anti-anxiety medication or refer you to a therapist. Finally, it is also important to be aware of other possibly undiagnosed sleep disorders that you may have, which can contribute to raising your risk of EHS. This is a conversation with your physician who can identify whether you have existing sleep disorder contributing to EHS or whether you have a sleep disorder at all.
Well, with that, I would like to say that this was a very comprehensive and informative podcast, to say the least. Thank you to our wonderful researchers, patients, and to all those that listen to this podcast. We hope that you learned something of value and that are now more informed and aware about the intriguing exploding head syndrome.